That sound is good? Okay. Well, thank you everyone for being here, and thank you, Sarah, for inviting me to do this seminar, the last one of the year. I hadn't quite realized that, so very glad that you all made it here in person, and for those of you online, welcome as well. So I'm going to give you a bit of an overview of some of the findings from the My Health, My Community survey that was conducted in 2013-2014. And by kind of giving you an overview, I also want to kind of draw to your attention that this is a resource that we are actually making more and more data available online over the course of the year. And this data is now publicly available for use for other types of analysis. And what I want to do today is kind of speak to some of the work that we've done to date, and then talk about some of the potential uses that could be used of this data set as we move forward. Now, how many people in the room, I can't ask anyone online, how many people in the room actually have done the My Health, My Community survey? So 1, 2, okay, not many, all right. So the My Health, My Community survey was conceived as a way to assess community health status down at a more granular level than has previously been conducted in British Columbia and possibly even parts of Canada. Traditionally, we've relied on the Canadian Community Health Survey to give us indicators of health and well-being at a community level, but for those of you that have used that data source will recognize that most of that data is aggregated to health boundaries, and those health administrative boundaries are fairly large. Now, in 2011, the BC Ministry of Health had come up with their new Healthy Families BC strategy, of which one component was healthy communities. Now, part of the work of health authorities is to work with local governments around influencing the social, physical, and economic environment to ensure it supports health and well-being. So with that in mind, we really wanted to engage our local governments on what are some of the health and well-being issues in their communities. And we hadn't been able to do that because when you speak to, in Vancouver Coastal Health Region, CCHS provides us data aggregated to 3 health administrative regions. And that data you cannot stratify by age or sex. Now, across Vancouver Coastal Health, we have close to 13 municipalities. So that was clearly inadequate for that purposes. So together with Fraser Health, we came together and developed this initiative, and also with the UBC eHealth Strategy Office, Kendall Ho at the time, to look at how could we do this survey in a way that hasn't been done in the past and reach a population that will actually be able to give us some really good data at the municipal level. So it was the campaign around this initiative was over a year long, and it was a bit of a call to action. And the call to action was, it's time to see the bigger picture in your community. What's influencing the health and well-being? The survey itself comprised close to 90 questions, and those 90 questions had a significant amount of stakeholder input into it. Stakeholders both within local government, academia, as well as health sector and non-health sector partners. And over the course of an 8-month period, we identified these 90 questions that were based on validated sources that other surveys may have used. And they generally fall into those 6 themed areas. The survey itself was primarily online. However, it was supplemented with extensive field outreach into the community at a variety of public events, as well as having paper surveys that were available in a number of harder to reach populations, so food banks, senior centers, places of worship, etc. And the field outreach team itself, comprised a number of multilingual speakers. I mean, at its peak, there were 20 field outreach staff that we had that would work across both the Vancouver Coastal Health and Fraser Health regions at a variety of public events. And together with a number of social media campaigns as well that did a fair amount of outreach. Now, our goal was to ensure we reached a representative sample of the population in the Lower Mainland. And so we had a target of 2% of the population aged 18 plus, so that's approximately 43,000 respondents. Now, just to put that into context, CCHS would typically survey less than 0.5% of the population in the Lower Mainland. So we went out for a 4 times larger sample based on some pilot work we had done that suggested that would be if we got a representative sample of that magnitude, we'd be able to do some interesting age and sex stratifications and look at a variety of equity dimensions as well as they relate to health and well-being. In order to hit that target, we actually did a fair amount of work up front to understand down to each municipal level and within some of the larger urban municipalities down to neighborhood level, what was the age, sex, ethnicity, education, and income characteristics of the population. And we had this running dashboard that we would look at on a weekly basis to see where were the survey respondents coming from. That way we could see where are the gaps in the respondents. Because with any survey, what you do after you've collected the data is you try to do a post-collection weighting. And that post-collection weighting, what it's trying to do is conform the data to make it representative of the population you want to speak to. And we were able to do the post-collection weighting for age, sex, and education, as well as geography. And the geography was depending on whether we're reporting out at a municipal level, it would be weighted to municipal values, census data, or it would be at the neighborhood level. And so this was quite an intense progress and kind of monitoring that we did throughout the year-long data collection process. And what it allowed us to do is where we saw some gaps, we could then work with some of our community stakeholders to say, okay, we're missing this particular segment. Might be an ethnic segment, might be an income segment, and then we would send in field outreach team into those settings, or we would partner up with, say, for example, like Success, which is an new immigrant support service, in terms of reaching out to some of the non-English speaking background individuals that use the services in those communities, in the communities across the Lower Mainland. So where did we end up? We ended up with 33,000 survey respondents. So that was kind of 77% of the way to that 2% target. And there were some differences across the health region. VCH was quite close to hitting their full target, and whereas Fraser Health was a little lower. That said, we still had sufficient data point here that with the post-collection weighting, we could report out on a number of different jurisdictions. And one of our first products was actually to have that engagement with local governments across both health regions. And we produced these community profiles, 30 municipalities that across Metro Vancouver, Fraser Valley, and the coastal rural part of Vancouver Coastal. And these profiles are all standardized format with fairly detailed information, health status indicators, built environment, community resiliency factors that previously hadn't been available at such a small level. So these are been in circulation since June of last year and are a vital part of the engagement we do with local governments around developing some of their official community plans and helping them to focus on what are some of the priorities in the communities that they may want to work on. Within the report itself, we've tried to keep the report as an 8-page profile for each community. We try to keep it highly visual, but the data has been broken down by age and sex wherever we could, as well as including some equity dimensions around household income, education, what are some of the variations that may exist. In this particular community profile, we released about 30 indicators, and they're all benchmarked, so you can actually make comparisons in relation to the health authority average, the BC average, as well as any national data that we may have. And those community comparisons have also been published online at the My Health My Community website to kind of show what are some of the rankings across the communities for particular indicators. And this particular indicator is looking at physical activity, so that's a proportion of people that are meeting the recommended 150 minutes or more per week. And you can see that across those 30 communities in the Lower Mainland, there is a fair amount of variation. The red line there is the Canadian value from the Canadian Health Measures Survey, and the bars in blue are the regional benchmarks that we calculated for Metro Vancouver, Fraser Valley, and coastal rural. And you can see that, so you've got communities like Whistler and Squamish that are at the top end of physical activity, and other communities like Richmond and Coquitlam, Hope and Burnaby that are at the lower end. Now, given that we had 33,000 respondents, of which just close to 28,000 were in Metro Vancouver, for Metro Vancouver municipalities, we could actually even break it down even further. And that's one part of the work that's been going on for the past 6 months to really further break it down from that municipal level down to the neighborhood level. And so just last month, we released neighborhood level data for about 106 neighborhoods in the Metro Vancouver area. And this data has been released in an interactive atlas, that allows you to see close to 90 indicators, so virtually the entire data set now. So 90, when you think of the number of respondents plus the number of indicators, that's nearly 3 million data points that went into this atlas. The atlas is designed to kind of give you a map that shows the distribution of any particular indicator across both health regions. You can zoom in to particular cities or regions or health authority. And in particular, you can also see the comparison across the community. So the bar chart there on the bottom there shows the variation across the two health regions. And that bar that's highlighted in red is UBC. And on the right-hand side, you've actually got the value for UBC. It shows what are some of the values for the UBC community in terms of sociodemographics, health status, lifestyle behaviors, and that the red dot there, or the red diamond there, is showing the percentile of that value in relation to that data set, as well as benchmark data that shows the health authority, the municipal value, as well as the regional value. So it's a fantastic atlas to kind of play around with. If you're online right now, by all means, go log into that website and take a look. And now you can zoom in on particular areas. So this is a zoomed in map of Metro Vancouver. So across Metro Vancouver, if you remember the earlier bar chart I showed you that showed the variation across the 30 communities, well, in fact, when you start to drill down, there is even more variation. So some communities that may have seemed low at the municipal value may have pockets where there's actually much higher physical activity. And the data you can, is using quartiles or whatever quantiles you want to specify. You can specify that in there. And the other thing that you can do with the atlas is you can actually look at the table of the top 10 areas. You can sort the table in the background to look at what are the top 10 areas for physical activity in Metro Vancouver. So in this case, the West Vancouver, North Vancouver District Municipality, the West Side, Kisilano, Bowen Island, Port Moody, Maple Ridge, South Surrey, White Rock areas in particular are among the top 10. And then when you look at the bottom 10, there's some of the more densely populated areas in Metro Vancouver, southeast Vancouver, Victoria, Fraserview, and Killarney area, parts of Burnaby, Metrotown in particular, Coquitlam Town Centre, etc. So you can look at this for right across all those indicators, and all this data can be exported as well. Now, one of the things you can do is also select, for example, this is looking at self-reported general health, the proportion reporting excellent or very good health across Metro Vancouver. And the data is already in quartiles. So the Metro Vancouver value is 48.5% of people reporting excellent or very good health. So here I've picked the bottom quartile. So these are neighborhoods that are significantly lower than the Metro Vancouver value. So, and this is something important to keep in mind. And I think when we look at most of these indicators, one important thing to bear in mind is that they're influenced by the social determinants of health. And we have included a number of those socioeconomic status variables in the atlas as well. So you can examine some of these indicators in relation to that. And I'll speak more to that in a minute. Now, when we think about the social determinants to health, we expect to see social gradients to a lot of this. And this is a graph showing the self-reported general health across education groups. So the blue being those with less than high school graduation, and the darkest green being those with a university degree or higher. And you can see across Metro Vancouver, as well as Fraser Valley and Coastal Rural, there is a fairly strong gradient to this. That's something just to bear in mind when you do look at the data. And if you remember the previous map that looked at general health and excellent very good, in fact, those are the same areas that tend to have lower household income as well. So this is now picking the quartile in which a greater number of respondents are reporting household income under 40,000. So, and I think if you notice UBC, it's perhaps not surprising, given the student population. Now, there are a number of equity dimensions to this data, and we are starting to look at some of these and put these into some of our other reports. But just generally speaking, just looking at the lowest income group, so less than 40,000 versus the highest income group at 120,000, there are a number of differences. So general health, much lower amongst the lower income. Mental health, self-reported mental health, again, that's reporting excellent or very good mental health, much lower. Obesity, no difference. Prevalence of one or more chronic conditions, much higher in the lower income group. When we look at it by education, so comparing just those less than high school versus those with a university degree or more, again, we find that physical activity level, so the proportion of people meeting the 150 minutes target a week is much lower in those with less than high school education. Screen time is higher in that group as well, so having more than 2 hours of screen time a day is much higher. In terms of meeting the 5 a day fruit and vegetable recommendation, that's much lower in the lower education group, as well as consumption of sugary beverages, so the proportion consuming 3 or more sugary beverages a week. So it's significant difference to a number of lifestyle behaviors here. Carrying on that theme, looking at another dimension of equity, given that we are an immigrant community, look at those by whether they're born in Canada or not. Smoking prevalence is much higher amongst those born in Canada. Binge drinking as well, so that's people that have been drinking 1 or more times a month. Fast food consumption is significantly higher as well, so that's consuming fast food 2 or more times a week. However, in terms of sleep, those born in Canada seem to get significantly less sleep. Significantly more sleep. They're less likely to report sleeping less than 6 hours a day. Now, we also collected some measures around their perception of the neighborhood, so the built environment. And again, there are social determinants to this, aspects of the built environment. So those in the lower income group actually report amenities are more likely to report amenities within walking or cycling distance. In terms of large selection of fruit and vegetable in their neighborhoods, there was no difference. However, significantly, the lower income group more likely to report living in areas where traffic makes walking difficult. And then in terms of perceptions of safety in their neighborhood, those in the higher income group were more likely to report feeling safe walking after dark in their neighborhood compared to those in the lower income group. Now, I'm going to transition a little bit to talk a little bit more around some of the built environment perspective to Metro Vancouver. And whilst where you live has a significant role to play, we also realize how land is used, how the infrastructure is provided across Metro Vancouver does also determine health and well-being. And in particular, transportation across Metro Vancouver has been a very topical issue for the past 18 months or more. And this is a map looking at self-reported whether people are within 5 minutes walk of a transit stop from their home. And perhaps seeing some of those darker areas is not surprising. A lot of those darker areas also relate to where some of our transportation hubs are, particularly the rapid transit. And this led us to examine the relationship between transportation and health across Metro Vancouver last year in the run-up to the transit referendum that took place. And across Metro Vancouver, we identified that 55% of residents commute to work or school regularly by car, and 29% use transit, 10% walk, and 4% cycle. Now that group that takes transit, walks, and bikes is the group that we're particularly interested in terms of active transportation. So we focused to to examine how does different modes of commute affect health and health behavior. And again, this report is available online if you want to take a deeper look at it. But what we found in general was that active transportation was associated with lower body mass index, a higher wellness score, that is having more positive lifestyle attributes. It was associated with more likely meeting the 30-minute walking a day target and more likely in meeting the physical activity target of 150 minutes a week. There was no association with self-reported health or sense of community belonging. In terms of active transportation, the most significant component of that is cycling and walking. Right? I think it's quite obvious why those would be the most beneficial. And these associations, unlike a lot of the data in the atlas, that's some of it's stratified, some of it's just a cross-sectional estimate, this analysis has actually been controlled for a number of socioeconomic variables, including health status, your commute time, as well as whether you're within 5 minutes of a transit stop. So we try to control for as many confounders as possible. One of the more significant findings was that using active modes of transportation for commuting decreases the odds of being overweight or obese by 33%. For transit users, that was 22% lower odds, whereas for biking and walking users, it was 48% lower odds. Another interesting finding was when we looked at commute times in relation to sense of community belonging, we actually found that those individuals that spend more than 50 minutes a day commuting were half as likely to have a strong sense of community belonging. So they were less involved with their community per se, potentially. And then people who commute by biking and walking have a 69% greater odds of achieving their recommended amount of physical activity a week. Now, how does this look when we look at it spatially across Metro Vancouver? And this map is looking at the active transportation users and try to put it into context of the existing transit service routes and areas. The solid lines here being the existing, and then the dotted lines were those proposed as part of the transit referendum. And first of all, you'll see that the darker purple area on the maps indicate areas where they are residents are more likely to walk, cycle, or use public transit, much higher than the Metro Vancouver average, whereas the lighter purple are those areas that are significantly lower. And you can see the concentration of the higher use is very much along those rapid transit lines and the regional town centers. Further analysis examined what are some of the differences in health characteristics between those in the dark purple versus light purple, and not surprisingly, there were differences around obesity, sense of community belonging, etc. Some of those previous associations that I spoke to. Now, obesity was one of the main findings that we were particularly interested in. And when you look across the various communities in the Lower Mainland, you can see that those communities with some of the lowest obesity rates, lower than the BC value as well as lower than the Canadian value, are actually some of those with the exception of Whistler, with some of the more denser populations and access to rapid transit. Or better transit, potentially. Now, another important component of looking at association of transportation is walkability. And after we had released the transportation and health report, we actually were able to obtain data from WalkScore. So WalkScore is quite widely used in the real estate world, and every single postal code of residence is generally assigned a WalkScore. So we were able to obtain a custom cut and assign the WalkScore to all the Metro Vancouver My Health, My Community participants, 28,000 of them. And this is just a spatial map showing the distribution of the WalkScore, and you can see that the green is the more walkable areas. In particular, the dark green is what's considered walker's paradise, and then the lighter green, the very walkable. And whereas the orange area is what's considered car-dependent areas in Metro Vancouver. And we did an analysis for the International Diabetes Congress that was here in Vancouver just back in December to look at how does walkability or WalkScore influence being obese and overweight. And perhaps not surprisingly, we found that those that lived in a Walker's Paradise neighborhood were 31% less likely to report being obese or overweight compared to those in a car-dependent community. And even those in very walkable areas had an 11% lower odds of being obese or overweight. And again, this analysis is controlling for a number of confounding factors, including health status, underlying chronic conditions, etc. Okay. Now, walk score is interesting in terms of it tries to be an objective measure of walkability. I think there are other indices out there that could be used. For example, Larry Frank's walkability index as well, that has a few more dimensions in it. But the other aspect that is interesting to look at is people's perception of the neighborhood. You may have a very walkable neighborhood, but you may not perceive it in that same way, or you may have other sense of fears around walking at night, etc. So within the My Health, My Community survey, we did actually include the CCHS module on neighborhood environments, and this is an 8-item question that examines different aspects of the built environment, but particularly being self-reported, it's a perception. And we use that to calculate a neighborhood perception index that's scored between 0 to 32 to see, well, how does that influence health and well-being? And this is a map showing that variation in neighborhood perception index by neighborhood across Metro Vancouver. Here, the green is those areas that are reporting higher neighborhood perception, particularly the dark green, being much higher than the Metro Vancouver value of 22.5. And then the peachy color being those areas that are significantly lower on neighborhood perception. I don't think there's any real surprises here. However, how does that perception of neighborhood relate to health status? So we took a look to see how does self-reported general health and mental health vary. So the blue bars here are now those that are neighborhoods with a low neighborhood perception index, and the green being those with a high neighborhood perception index. And you can see those in the high neighborhood perception index were more likely to report excellent or better general health, as well as excellent and better very good mental health. They were also significantly more likely to have lower levels of obesity and less likely to report having chronic conditions. In terms of lifestyle behaviors, that also plays out in terms of physical activity. Those in a high neighborhood perception area tend to do more likely to meet the 150 minutes a week target. Screen time, no real difference, but again, in terms of healthy behaviors, both fruit and veg consumption much higher, and in consumption of sugary beverages much lower. Now, other lifestyle behaviors, smoking marginally higher in the low perception index. Binge drinking was lower as well in the low perception index. Fast food consumption was higher in that group as well as less likely to or more likely to sleep less than 6 hours a day in those low neighborhood perception areas. In terms of how does it influence your transportation, what we're seeing is that commuting by car is much higher in the low neighborhood index areas, perception areas. Commuting by public transit is also higher. However, when we look at it by active transportation, those in the high neighborhood perception areas are more likely to report commuting by active transportation. So if you look at that in relation to the previous bar around public transit, it's presumably speaking to the walking and biking of the neighborhoods. Those in the low perception neighborhood index were also more likely to have commute times that were much longer than 30 minutes one way, and more likely to also be exposed to secondhand smoke in public places. So we're seeing some real differences here in not only by some of the equity dimensions, but also by how individuals are perceiving their neighborhoods. And this is also borne out in the resiliency of the communities. So strong sense of community belonging is much lower in those low neighborhood perceptions. Having a social network or 4 or more people to confide in is also much lower, as well as food security, those having enough to eat on a regular basis, was much lower as well. And then in terms of emergency preparedness, having emergency supplies for 3 or more days was also significantly lower in that group with a low neighborhood perception. So, all in all, I think this data set here provides us with an opportunity to examine how place affects health and well-being. I think where we live, work, and play is largely influenced by where we live and where we spend most of our time. And this is a large granular data source that we've started to now make available publicly, primarily to inform a lot of our municipal government partners around some of the work that they can do to creating health promoting environments. It will inform some of the planning decision and policy development for community programs and services, and in particular making it relevant to local level health and wellness needs. I think with previous data which has been aggregated to health boundaries, we're really not doing a local level needs assessment, which makes it harder to be more targeted and focused around what's needed. And I think by looking at the different dimensions of equity, I think it's very clear, and when you think about those neighborhood perception scores as well as the socioeconomic status variation across Metro Vancouver, it's very clear that those differences are influenced by land use, transportation, housing, food environments that are available, as well as green space. They're all important determinants of lifestyle, social capital, and physical and mental health outcomes. So I think investment in those areas and trying to understand them and unpack some of those will have dividends in health and well-being. Now, the work that we've been doing is ongoing in terms of releasing what's available publicly, but then there's also other regional reports that we're working on. For example, we're working on the primary care initiative that the ministry has around GP attachment, and we're examining what are the determinants of having a family doctor in Metro Vancouver. Now, we can use the My Health, My Community data set, all the 33,000 respondents to look at that, but in addition, what we've been able to do is now to incorporate other data sources. So as a health authority, we have access to emergency room utilization data, so we can see, does having a primary care physician in Metro Vancouver influence ED visit rates? And preliminary analysis is very suggestive of that, and that work is ongoing, and we hope to release a report later this year on that. Another area of work that we're working on together with UBC Help, the help team here, is looking at what are some of the determinants of Early Childhood Development Index, the EDI scores. And so we've recently been working with the EDI team to examine the neighborhood level differences. And this work, again, we hope to produce later in the year. But one of the key things around putting all this data out there in this atlas is that you can now incorporate other open data sources to examine associations. I mean, clearly it's a cross-sectional survey, so all you're doing is looking at associations, not necessarily causality. But given the number of open data sources that particularly speak to green space, land use, transportation, I think there's some interesting associations to be examined and explored over time. So, on that note, I will leave it at that. Okay. Oh, sorry, I do want to acknowledge that this work would not be possible because of had there not been a number of very dedicated individuals over time. And in particular, I want to acknowledge the recent work that was done in getting the atlas out there. Jeff Ramler, GIS specialist at Fraser Health, as well as Eleni Kefalis, public health information analyst at Vancouver Coastal, both very instrumental in getting that, together with Salman Klar at Fraser Health, Yumian Hu at Vancouver Coastal Health, and Corey Green and Katie Tweedy as well around some of the engagement work to make sure that the atlas was meeting the needs of our local government planners. So, thank you.
Thank you very much, Jat. I'm going to start with a personally motivated question because I was telling my class today, if you're going to embark on some sort of sampling or survey campaign, your best defense is very good planning up front. So can you tell us a bit about the planning process for the My Community, My Health survey?
Yeah, I think when I came to BC in 2007, it struck me quite early on that we actually don't really know what's going on in some of our communities, and the data that we were getting from both national and provincial surveys was just inadequate. coupled with the loss of the long-form census in the last round of the census, just meant that there was a dearth of data to try to understand that social economic environment at a granular level. So that prompted us to do 2 pilot initiatives, and one was the Healthy Richmond survey that was done in 2011, and then later that year we did the North Shore Child and Family Friendly survey to examine some of the childhood environments on the North Shore. And both of those were essentially pilots to doing the My Health, My Community. We had an online survey together with field outreach, but critically we had actually done the work to establish targets down to the small area level at the neighborhood using census data to look at age, sex, ethnicity, education. Typically CCHS in the past is largely English based. It's a telephone survey, so it's only reaching a certain segment. I mean, all surveys are not perfect, but the question is, if you do that work up front to understand who are the respondents you want to hear from, what it allows you to do is that, and in this case in particular, is that the post-collection weighting, which you have to do with any survey, the weights you apply are a lot smaller. So you're more likely to get stable estimates. And I think the case in point was in Richmond, where CCHS released data that showed that smoking prevalence in Richmond had jumped from the previous cycle of 15% up to 21, 22%. But the confidence intervals around those estimates is like plus or minus 5%, right? And if you look at most of our confidence intervals, they're fairly tight, especially when you're looking at those municipal levels. This question behind you. Oh. Okay. Yeah.
Thank you very much. An impressive data set. I actually have 3 questions. Hopefully some of them are quick.
We got time.
Yeah, the first one should be quick. Did you ask what people do for work?
No, we didn't.
Okay.
It's this survey in its current incarnation didn't ask that, but might be something we might think about in the future. But I think
personally motivated research.
But I will tell you one thing though, that one of the reasons why we didn't weight in this data set by income is the fact that income was probably one of the socioeconomic variables that was least well reported, or there was a lot more gaps in the data. So.
Not uncommon on the CCHS too.
Yeah.
Do you know why there is such a difference in the response rate between the 2 health authorities, or can you guess why that happened?
I think there are a number of factors there. I think there is outreach work that was done. There's also a different population in terms of how they may perceive health and well-being. I mean, I think if you look at most of the data that's always released, we're always, I think the Vancouver respondents generally are more vested in health and well-being compared to some other municipalities. But I think really it just boils down to outreach and the time we had. And I don't see that as being a significant issue in terms of the difference in response. Yeah.
And final question, playing devil's advocate a little bit. How much of everything that you presented do you think could be solved by increasing income levels at both the individual and the neighborhood level, or reducing the discrepancy between high and low income, full stop?
I think in public health we often look at how do we influence that socioeconomic environment to be able to improve things. However, I think there are probably others who are a better place to answer that question, because I think any kind of increase in income also has knock-on effects in other areas as well. And so do I believe in an increase in minimum wage? Definitely. How do we do it? I think that's the issue.
Thanks, that was really fascinating. I was wondering how you went about defining neighborhoods, and also if there was variability in the source area and numbers of population across different municipalities.
Mm-hmm. Yeah, no, that's a good question. So all the neighborhoods were defined largely based on the neighborhood planning areas that local governments use. So we actually went to City of Vancouver, City of Richmond, etc., and asked them for their shape files for the neighborhood. Because at the end of the day, if this data is going to be useful to the planners, it's got to speak to their same coterminous with their planning areas. That said, though, given the response in some areas was lower, we did have to aggregate a couple of neighborhoods together. So So it's not exactly the same as the neighborhood planning areas. I think in Vancouver we had to, the Oak Ridge, Shaughnessy area, or Arbutus area around there, we had to aggregate. There were several in the Fraser Health region as well. And where we didn't aggregate, I think what you have is you can get a cross-sectional estimate of any of these indicators. However, you're unlikely to be able to do any age or sex stratifications of that. Making you walk around the rooms there.
Thank you so much, Jat. I know you've touched on it a little bit in your presentation, but I was wondering if you could expand on how your outreach team looked like. Like, did you involve environmental health officers on the ground, or do you have community health specialists working in the team?
So we did definitely involve our frontline staff and raise awareness amongst our frontline staff around it. But the outreach team itself was primarily MPH students that we had hired during the course of the year in summer, and MPH graduates that worked as part of a team. We did have some events that some of our other healthcare staff were more heavily involved in promoting it as well. So, for example, the Vaisakhi Day Parade, our environmental health officers had actually done a lot of work because they're going out there and delivering messages around food safety. They also delivered messages around the My Health, My Community survey as well. Yeah, so I would say primarily it was based on that student workforce outreach team that we hired over the course of the year, but some frontline staff involvement as well, including myself. I was at the Sun Run in BC Place, where we did recruiting there over a day as well in different community health centers.
Hi,
Hi.
and thank you. I wanted to understand a bit more about the scale that you've developed for the perception, the Neighborhood Perception Index. What was it measuring exactly? What perception were you trying to tap into?
Well, I think it's based on the CCHS built environment module, and so it captures things like your perception of whether your neighborhood has separate paths or trails for cyclists and pedestrians. Is the sidewalks in my neighborhood well maintained? So clearly, things like that are more relevant to Metro Vancouver urban communities than rural. So we only focus that analysis for Metro Vancouver. Whether you have shops, restaurants, and amenities within easy walking and cycling distance, having access to a large selection of fruits and vegetables available in my neighborhood, attractive natural sites, so green space, the perception around neighborhood, traffic, as well as safety. So those dimensions there that, I think this is a preliminary look at how does it look across our data set, and we've been validating this against what CCHS has been collecting as well.
So the reason I'm asking is because I'm looking at built environment characteristics. So, for instance, I'm looking at things like objective measures of green space, walkability, bikeability, and these type of features. And sometimes when we do associations and look at health outcomes, we find very surprising effects. And my thought is that maybe perception plays a big role in there. So did you get a chance to look at how perception, your scale, fits with the actual objective measures? Because you are working with walk scores, for instance.
Yeah, so I think I can't speak specifically to that, but I do think there was an association there. But that's one of the reasons why, when I mentioned in my last slide, I think there are lots of open data sources out there around land use, particularly around green space, about grocery stores, etc., the density of that. And I think the next part of the work is to try to see whether some of those dimensions in that neighborhood perception correlate with what's reported objectively or recorded objectively. Yeah. I suspect there will be.
So one thing that's interesting about My Community, My Health survey is that you had a lot of early evidence available for the transit referendum last year, and it did help to inform the discussion, I think. The transit referendum didn't necessarily go the way that many of us in this room would have liked it to go, but do you know how communities are acting on this information that you're making available to them?
Well, so within our Vancouver Coastal Health Region and also in Fraser Health, we have our healthy community partnerships that operate together at a quite a formal level with the local governments, where we're signing official community plans. And one of the things that we've been doing in trying to developing these official community plans is trying to take the data out to them and speak to them. So, for example, going to Squamish, speaking to the council there around what is the health status of Squamish residents based on the community health profile. The two things that kind of struck them of interest was, one, the fact that they have a fairly young population with a high number of households with young children, so they're really interested in the early childhood environment. Then the other aspect that they are largely a car-dependent community, but there's options to increase active transportation within that. So the early focus for Squamish has been around active transportation and early childhood development. So these conversations are happening at different local governments all the time. Any questions online?
No, the online audience has been surprisingly quiet. There's a lot of them, but they're not saying anything. Okay, everybody, if there's no further questions, we'll say thanks for another excellent year. Thank you to Jat for doing our final presentation, and we'll see you in September.